Good afternoon, everyone. iTech India welcomes all the participants for today's NDLS session. Today's topic is immunization among children living with HIV, and the speaker is Dr. Kalpana Datta. Dr. Kalpana Datta, ma'am, is the Program Director of the Pediatric Center of Excellence in HIV Care and the Professor and HOD, Department of Pediatrics at the Medical College Hospital, Kolkata. She is also the in charge of the Adolescent Clinic at Medical College, Kolkata, and a national trainer for malnutrition, pediatric HIV, early child development, and the National Tuberculosis Elimination Program. She has authored numerous papers published in both international and national journals. Please note all the questions will be put in the chat box today. Due to time constraint, we won't be able to take up questions at the end. So please put your questions in the chat box and we'll circulate the answers along with the PPT. We welcome you, ma'am, for today's session and request you to start the session. Ma'am, you're on mute. Ma'am, please unmute. Requesting participants to kindly bear with us. Ma'am, can you please unmute? Kiran sir, am I audible?
Yes.
Okay.
Or am I audible?
Yeah, ma'am, you're audible. You'll have to share the screen again.
Okay, so I'll stop it and then again share.
Yes, yes, ma'am. Yes.
Is it visible?
Yeah, it is visible. Please switch to full screen mode and click hide.
Okay.
Yes,
Is
ma'am.
okay?
Yes, ma'am.
Okay, so whatever I said, I think it was not audible before.
No, ma'am. No.
Okay, so again, I'm starting. It's a very good afternoon to all the participants and the attendees who have joined today. Thank you, Sheta, for your nice introduction. Today, my topic is immunization among child living with HIV, and immunization is very important aspect of the pediatric care. So, as important as the continuation of ART2. So, I'll request all the participants, please, you yourself do practice and also spread the message to bring ask the parents or caregivers to bring the immunization card and always go through the card. Still, we are getting many vaccinations are missed by the parents. So, it's very important to give the advice age appropriate vaccination, and you don't have to remember that schedule. You just see the card and ask the parents to take the vaccination. And now the immunization card has been changed and the name is MCP card, Mother and Child Protection Card. And there not only the immunization, the feeding and the milestones are written according to the different age group up to 3 years. So it's a very important book, and you ask them to go through the book, read the book, because I have seen, is my own experience, they take the card while even giving the immunization, but they don't go through the book, they don't know what is there. So it's very important to bring the card and yourself you see and ask the parents or caregivers and encourage them to read. So today's topic is first I will say a few words on the basics of immunology. What are the vaccines available? How the vaccine having an impact on the disease? If we won't give the vaccine, what will be the disease severity, incidence of disease and all? And what is the efficacy and safety of vaccine in immunocompromised child? What are is there any adverse event which is much more compared to the normal child or not, and what are the adverse event you can expect? How will you counsel about the adverse effects and all? Vaccine schedule for children living with HIV, what is the government's immunization schedule, and what are the vaccines available in the market, if you can give by some fund generation or by donation or by some NGOs, we can give those vaccines which are though not in immunization schedule by government of India but available in the market. So immunization, what is immunization? It is the proven tool. It is a control and eradication of infectious disease. So this is one of the preventable things which have in our hand. If you give the vaccines, that can prevent the disease, and this is quite cost effective. You know, the maximum cause of death in under 5 is a pneumonia, diarrhea, and malnutrition. And this pneumonia and diarrhea, a great extent, can be prevented by vaccinations. So if you can prevent the pneumonia and diarrhea, automatically the malnutrition will be indirectly be prevented. So Indian Academy of Pediatrics has established the guideline for vaccinating children with HIV infection, because we don't, government of India does not have any guideline for, especially for HIV children. CDC is American Community Immunization Program, WHO recommended immunization guideline for HIV infected children. Now we can follow that also. So this is very small script, difficult to read for you people. It's just a milestones written in the Universal Immunization Program in India, how it has been started. It started in 1985, then again it intensified in 1990. Then there's a mission in the Indradhanush was started in 1990, which is again intensified. That is called IMI, that is intensive mission in the Dhanush. Then every year there is some points is added in the immunization and the reinforcement of the immunization procedure. Again, in this year also we have, last year also we have a MR campaigning, and MR campaigning was done in the IMI, that is IMI is the intensive mission in Dhanush. This year again we are having, going to come in September, October, November also, again there will be one mission for campaigning for measles and rubella vaccinations. So it is under the IMI again. And revised national immunization schedule was launched in July 2024 by government of India, and I'll make discussion at the end. So importance of immunization among child living with HIV. What is the importance? If you give the immunization, what benefit you will get? HIV infected children are more susceptible to disease. We know, as they are immunocompromised. The pediatric patients are, as such, they are immunocompromised if you compare with the adult. And if moreover they are HIV infected, then they're much more compromised, and the chances of infection are quite high as compared to other children. HIV disease progresses very rapidly in young children, often leading to death. 30% they die in the first year, and if you're not going to treat in the second, they don't see 40% they don't see at the second year. So there is a rapid progression of HIV disease. And if you won't prevent the complications or the preventable disease by vaccination, that will enhance the death. There is an increased need for vaccination against all vaccine-prevented disease, not only the HIV positive children or exposed children, but also all children. It should be 100%. It is important to ensure that they receive all recommended immunizations. The counselor should review the immunization record to identify and miss immunizations and arrange to redress as soon as possible. No, I say it's not only the counselor who are there in the ERT center. Each and everyone has the responsibility to reinforce about the immunization schedule, whether mother parents are following or not. So whenever you have come in contact with any patient and their caregiver, must re-emphasize about the vaccinations. So what happens, we know in our body, there are two types of immunity. One is innate, means naturally acquired. We have that from very beginning. And this adaptive means the body adapts for the stimulation what the body receives. So innate maybe the skin, it may be neutrophils, monocytes, macrophages, natural killers. So this is already there in the body, and they will prevent the entry of the infection from the skin barriers, and they will kill the infective organism by the neutrophils, monocytes, macrophages, and all those things. So it's already there in our body, which is existing. And when there's an infection comes, it fight against that infection. But what is adaptive immunity? Means it forms something after getting stimulated by some infective agents. So it is provided by the lymphocytes. So we know that T and B lymphocyte cells are there. When any innate antigen comes inside the body, that innate immunity tries to trigger killing that. When they are not able to kill, all the organs not able to kill by the innate immunity, they form an adaptive immunity by presenting this organism as a presenting antigen to the B and T lymphocytes. And then there is a T cell immunity, formation of antibodies, different antibodies for protection of the infection, and that is called adaptive immunity. So vaccines that stimulate innate immunity are better immunogens. So which stimulate, they fight the innate immunity to act immunity, are better immunogens and persists for long. So that immunity that we said, this active adaptive immunity, how we get it? Active versus passive immunity. How do you get the active immunity? Active means the body has to react. So when there is a infection, it may be clinical, it may be subclinical. Like in jaundice, when it may be clinical. In pediatrics, usually it is clinical, but in adult it may be a subclinical also. Or sometimes in pediatrics, maximum cases of jaundice are subclinical. They don't have icterus. It behaves like a viral infection, and baby will get immunity, and that is called natural immunity by infection. And another is the active immunity by vaccination. We do give some vaccines, since we are introducing antigens, body react against that vaccine, produces antibody and protects the child. That is called active immunity by vaccinations. So active immunity resistance developed in response to stimulus by antigen, means form of vaccines, and is characterized by the production of antibodies by the host. What is passive immunity? Passive immunity means body does not have to do anything. It is getting ready-made antibodies from others. So it may be natural, it may be artificial. In case of natural, baby gets that passive antibody from the mother during third stage of labor in the third trimester, but there's a placental transfer of antibody from the mother to the baby, or during the breastfeeding also, baby will get some antibodies from the mother, and that is a natural antibody because direct antibodies coming from the mother to the baby. And there's an artificial means when we give the antibodies, monoclonal antibodies, or we give some immunoglobulins during some disease and all, and that is called passive immunity. So immunity conferred by an antibody produced in another host. So body does not have to produce any antibody, just ready-made antibodies given to the body is called passive immunity. So active versus passive immunity, we talked about the specific defensive immunity like active immunity, passive immunity, but just now I discussed natural. It may be natural means by infection, which may be clinically evident, may not be clinically evident, that is called subclinical, and acquired the following vaccination. Same slide is repeated. And the passive immunity, transfer maternal antibody through placenta, through milk, and acquired immunity is the by following administration of immunoglobulins or antisera. Now, what are the immunizing agents we give? Like the vaccines, these are maybe antisera like diphtheria, antitoxins, immunizing agents, and immunoglobulins like HBIG and all, RIG in case of rabies and hepatitis B and chickenpox and all, immunoglobulins. So vaccinations are made by giving antigen to stimulate the immune response through active immunization. When you give the vaccination, that will stimulate the body, and is an immunobiological substance designed to produce specific protection against given disease. A vaccine is antigenic but not pathogenic. So whenever the agents which are given in the vaccinations is having some antigenic, retain the antigenic property but destroy the pathogenic one. So there are different types of vaccines, and especially in HIV, be concerned for the live attenuated vaccine. What do you mean by live attenuated vaccines? Because they have the organisms are live. They are immunogenic but not pathogenic. That's why it is called attenuated. So when you give this live attenuated vaccines, especially in immunocompromised child, if the immunity is normal or CD4 is high, immunosuppression not that much severe, then it may be given. But in severe immunocompromised child, what will happen? These live attenuated vaccines, the antigens, the organism which are attenuated, becomes pathogenic, and that may cause disease. That's why live attenuated, while giving the live attenuated vaccine, you have to see the CD4 and immune status and other conditions before prescribing the vaccine. Kill vaccines may be inactivated toxins, toxoid, kill organisms, so there's no problem in giving the kills vaccines. Wholesale inactivated vaccine, again, it may be pertussis, rabies, IPP, Hep B. There are different toxoids are there, like diphtheria and tetanus. Subunit vaccines contains only antigenic part, so some part of the vaccines in the subunit are given. Protein vaccines may be cellular pertussis, HPV, some influenza vaccines, pure polysaccharide like typhoid, PPSP, meningococcal polysaccharides. Nowadays, we're more concerned about the conjugated vaccine than the polysaccharide vaccine because conjugated polysaccharide vaccines are available. That is typhoid and HIV, H influenza type B. Virus-like particle, HPV, and DNA and RNA vaccines like the COVID-19 vaccine. What are the immunoglobulins and anti-sera? Human normal immunoglobulin can be given in a hepatitis A, measles, rabies, tetanus, and mumps, but human specific immunoglobulin like hepatitis B immunoglobulin, varicella immunoglobulin, though it's not available all the time, varicella, chickenpox immunoglobulin, and diphtheria immunoglobulin. Non-human immunoglobulin, maybe diphtheria, tetanus, cascade, botulism, and rabies. So immunization and effective HIV infection. Now, what is the difference between the normal child and HIV infected child? If you give the immunization in a normal child and if they give immunization in a HIV positive and exposed child, what will be the consequences? So majority of the children born to women who are infected with HIV do not acquire HIV infection. We know if you won't interfere, you won't give any prophylaxis and giving the exclusive breastfeeding, then the chances of having positivity is 40%. So 60% is really spared without any interference. But if you give the proper antiretroviral therapy, the proper antenatal care, delivery, and the postnatal prophylaxis to the children, newborns, then the chances, and giving the breastfeeding, then chances are only 2%. And without breastfeeding, it's 1%. So 99% won't get the infection while traveling through the antenatal, natal, and postnatal period. Those children who do not become infected most acquire the virus from their mother during delivery or shortly thereafter. So maximum transmission takes place during the perinatal period, during the process of delivery, and 20% may be from the breast milk. Early in life, they are immunogenically normal and immunosuppression will be minimal. What happens if even the baby will get infection at the time of birth or from the breast milk, it will take some time to suppress the immune system. So they are not immunocompromised even in after birth. All the normal vaccinations, primary vaccinations are supposed to be finished by 3.5 months. That's 6 weeks, 10 weeks, and 14 weeks. But that's 6 weeks, 10 weeks, 14 weeks. Till then, they are immunologically normal. But if at all there is a immunosuppression, that is very minimal immunosuppression. That's why what are the vaccinations are there in the government schedule for normal children should be given in HIV exposed and infected children. HIV infected children develop immune dysfunction affecting all aspects of immune system with increasing age. So when they become positive, then it will take time to suppress the immune system. And when you hamper any growing thing, there will be disturbances. So this immune system is growing up in a children. It is in a growing phase. And if that time there is an infection, so that dysregulation will be there. So immune dysfunction will be there. And they will behave to the vaccines in a different way. Results in increased risk of severe disease from vaccine preventable infections is very important because they are immunosuppressed. So if any infection happens to be there in the infected children, that will be more severe form. It will increase morbidity and mortality, and of course increase the other complications. This affect the quantity, quality, and process of protective immune response to the natural infection or vaccination. So if there's immunosuppression due to HIV, if you give the vaccines, the quantity might be needed is quite high than compared to non-HIV children, and then it may persist for less duration, or the antibody level may be lower than the non-infected children. It's not changing. Okay, thank you. So immunization in children living with HIV, the following areas of concerns are critical to the children. So why we are concerned? If you are going to give the vaccine, will be effective? If it is given in a normal children, we know it is effective, quite well tested. But if you give an HIV positive or exposed children, will it be effective? So that question comes in mind. Are children receiving a live viral vaccine or bacterial vaccine subject to significant increased risk? Because they are, as I already said, live vaccines are attenuated. So they are antigenic but not pathogenic in a normal children. But in immunocompromised children where there's severe immunosuppression, this viral organisms or bacterial organisms may become pathogenic and can cause disease. So this is a concern. Now, does administering vaccine significantly affect the rate of HIV-associated disease? So, if you give this some vaccine, will it affect the progression of the disease, HIV, or any other complications is there, or any opportunistic infections there, that whether it can be affected by the vaccination or not, that is also concerned. So, what happens when we give the vaccination? These are the points to be noted by the impaired seroconversion. What do you mean by impaired seroconversion? Means the formation of antibody which is not up to the mark. The clinical efficacy. If the antibody level is quite high, then it will be clinically effective for preventing the disease. So we are concerned whether it is there or not, because I have done the study in measles patients after giving two vaccines, 2 doses of vaccine, and we tested the antibody after 6 months of the vaccination, and we saw there's a huge number of patients, and more than 50% of children are having the measles antibody below severely low, and it recommends the second vaccination in such a decreased seroconversion in a positive children. Need for increased amount or number of doses. So whatever we do, we in our normal children, that amount should be given, or increased number, especially in heavy. It is said with the double units, like 10 units to give in a pediatric patient. Here we might need 20 units. Sometimes you might need 4 doses, in spite of rather 3 doses. So that to be concerned whether we need the increased amount or increased doses. Safety issue associated with live vaccines. As I said, live vaccine may act as a pathogenic if there's a immunosuppression, and that should be taken care of while talking about. Even not only the mother, the particular child, if another kid is there in the family and he is not HIV positive, and you are giving like oral polio, and there's a excretion of polio virus by the stool, and that may infect the other kid who is positive. That should be taken care of also. Decreased duration of protective efficacy, so it won't persist for a long period. You might need a reboosting or the more boosting dose of the vaccines. That should be considered. Effect of vaccine on the rate of HIV progression. So it does, the vaccine will cause the rapid progression or any alteration to HIV virus. So HIV infected in, what happens when the baby is getting infection from the mother, and mother is also HIV infected. So mother is immunosuppressed. So mother's antibody level is low, and we know the antenatal baby is getting antibody from the mother. So mother is having the low antibody. That means low transmission of antibody to the baby. So they don't get the protective antibody in sufficient amount. Then poor transplacental acquisition of antibodies. Then as the poor transplacental transfer of antibodies, babies are more susceptible to infection and more susceptible to younger age. And what happens, as mothers are positive, mothers having immunosuppression, the mother will have a different diseases. So that will transmit and cause the congenital infections, postnatal infections, and more chances of infection to the kids. So mother get infected with the vaccine preventable disease and expose the child to them. So there is an increased morbidity and mortality in HIV infected children from vaccine preventable diseases. If you see some studies, hepatitis B and HIV are shared common risk factors and mode of transmission also. Co-infection increases the mortality by 8%. HIV infected children are also vulnerable to reactivation of occult HIV. We know hepatitis B, if hepatitis B infection is there, in normal immunity can try to get rid of hepatitis B in the normal children, but that occult hepatitis B positivity can be a chronic disease, more chances of chronicity and the liver cancer in the adult if they are HIV positive. And you know, the HIV-E antigen that indicates the infectivity. So lower rate of loss of serum immunity, because normal children, what will happen if there is a hepatitis B infection, there's the E antigen, body immunity will try to get rid of that, and there will decrease in the HB antigen, and ultimately will be lost. But that is least chance of losing an E antigen in a HIV infected children. Then TB, you know, positive children are increased risk of TB, and more than near the half of the children will have a TB more as compared to normal children. Infection with HIV is a strong risk factor for progression to LTBI, to the disease. We know in our country, we are not going to treat the LTBI in normal children or normal person, but we are giving the INS prophylaxis to prevent the LTBI to become disease. That's why you give the INS prophylaxis while treating the children with the ART and INS. It is more severe, progressive, and likely to occur to extrapulmonary. Commonest pulmonary tuberculosis in children is the pulmonary tuberculosis, but in case of HIV, it becomes extrapulmonary, the common one, and it becomes more severe, progressive in nature, difficult to treat, and sometimes may become more resistant, and the drug resistant is quite high in a child living with HIV. There is a recurrence and relapse is quite high as compared to normal children. The mortality rate is high, especially when CD4 count decreases. If you see the measles on HIV again, there is some study. It has been shown that we know the measles is common in 9 months and onwards, so the vaccine is given in the 9 months. But what happens? Whatever the antibody comes from the mother, it passes over 6 months. So 6 months to 9 months is called a window period, and that is the vulnerable period. But in case of children who are non-HIV, there is hardly any infection if there's no direct exposure and all. But in case of HIV, there's a quite high. If you see the study, the 33% of HIV infected measles, and in case of 25% non-HIV infected period, because 6 months to 9 months is a window period. Less than 6 months, very rare in 5%. But in case of HIV, it is 9% because sometimes antibody disappears early, and then chances of having measles infection in younger age group. And it's quite high if the measles will be there in the younger age group, the mortality is quite high as compared to the uninfected children. So HIV infected gets measles infection at younger age are more likely to die of measles. Of course, if it won't die, increases the mortality, malnutrition, and pneumonia. H influenza, again, if you talk about the H influenza, it is also quite high because H influenza not only causes pneumonia, it also causes meningitis and otitis media. After the implementation of pentavalent, we know from the government of India, the H influenza meningitis is quite less. We don't get such a common 1 and 2. Very rarely do get in the meningitis. Pneumonia also decreased due to H influenza type B, and of course the otitis media. So if you see the 15% to 27% bacterial pneumonia of known etiology are caused by H influenza. And after starting the pentavalent, it has decreased. Now the commonest cause is the Streptococcus pneumoniae. And I hope that Streptococcus pneumoniae will be also decreased because now it has been implemented in the government of India all over the country. So I think pneumococcal disease also be less burden in near future. Mortality rate is 11.5% have been reported. So H influenza type B transplacental antibody transmission does not take place so much. So they are more prone to develop meningitis, pneumonia, and otitis media. If you think of the varicella, it is really very typical pictures, centrifugal, it starts the rash, papules, vesicles in the trunk, then spreads to the limbs and all. But in case of HIV children, it is atypical. It can appear suddenly. It can involve the more in number. It can involve the mucosa membranes inside the mouth cavity, vaginal mucosa and all. It can be hemorrhagic, and it can persist for long. There is a bleeding and purpura, thrombocytosis. There may be DIC also, and complications is quite high if you see, like pneumonia, hepatitis, encephalitis, DIC, retinitis, and having a stroke in children is quite common if the baby suffered from varicella in the past. So if you see 100, more than 100 times likely to have a varicella zoster in the future if the baby suffers from varicella in the early age. Okay. If you talk about the pertussis again, even in I studied with the pertussis in the last 2 years, so we have seen even in the vaccination given and all, there is a chance cases. We do get 2 or 3 cases in our center, the pertussis bacterial diagnosed positive, PCR positive pertussis cases still now. So it is more common, more even after the vaccination. So more severe prolonged course of HIV infected children will have if they suffer from pertussis. So now this is all about the disease burden and the increasing morbidity and mortality. Now we'll talk about the vaccine efficacy and the seroconversion rate. Means how far it is protective if you give the HIV in the children. Risk of developing disease is not possible to evaluate because risk of disease in individual different. Efficacy of vaccine, no vaccine provides 100% safety. Though it's a high degree of protection, like 99, more than 99 protection we see in case of measles, mumps, rubella, vaccine, diphtheria, tetanus. So it is all studied in a normal child, not there's no study in the HIV children for measles, because we have seen measles antibodies quite low even after giving the 2 doses in HIV positive children and exposed children as compared to the normal children. High protective efficacy in polio, BCG, Hep B, and pertussis vaccine. Moderately protective is in case of cholera, typhoid vaccine, and influenza vaccine. Concern regarding HIV defective vaccine response in HIV infected host means how far it will be, it will last. Antibody lasts for longer. Defective primary immune response. Already immune response which is there, immune system which is defective due to HIV infection. So destruction and functional alteration of antigen presenting cells, because in the very beginning I have shown you the innate antigen innate immunity will present the antigen presenting cells to the T cell and B cell, and then they will produce antibodies. But these antigen presenting cells are altered, destructed, then there will be no formation of antibody. Direct effect of HIV on B cells also. So B cell production will be less. High level of antigen non-specific hypergammaglobulinemia. So there may be this hypergammaglobulinemia will reflect the dysregulation of immune system in the body. Failure of B cell to proliferate on stimulation. Defects in generation of immunological memory cells. Memory cells required for long-lasting immunity. So if there's no production of memory cells, then there's no point in giving the boosting. When we give the boosters, the first booster, second booster, whenever we give the boosters, it will stimulate the immunological memory cells for production of antibodies for longer period. So that is also defective. The indirect effect on HIV impaired the T cells, help on B cell. And defective capacity of B cells to differentiate in response to CD40 and B cell receptor trigger. So immune memory is also less. Clonal deletion, depletion of memory T and B cells can happen in HIV positive children. And about the BCG vaccination, if you see 70% response rate in children born with HIV negative mothers. So what negative, the 70%, though it's not 100%, it does not prevent the tuberculosis. It prevents the spread and the severe form of disease. For meningitis, miliary tuberculosis, endobronchial tuberculosis will be less in a BCG vaccinated children, which is further less in case of 37% only in case of infected, and 50% in HIV exposed but uninfected children. So BCG vaccination induces immune changes in HIV exposed infants. And the BCG we say it's given just after birth, because we already discussed there's no such decreased immunity at birth or impaired immunity, which is less. Though the BCG is a live vaccine, it can produce some protection. But that's why we say if you don't give in the first at birth or after a few months, don't give after that. But in normal children, can give up to 1 year according to the government of India. But according to Indian Academy of Pediatrics, you can give up to 5 years in a non-infected children. But in case of HIV positive or exposed children, you can't give after that. Measles vaccines, again 20 to 30% HIV infected children have responded to single dose, but we do give a double dose at 9 months and 15 to 18 months. Then, of course, every year, as I said, intensified mission in the terms IMI. There everywhere there's a campaign mode, and we give in the campaign mode except in a severe immunocompromised children. So if you see this vaccine associated adverse event and death were uncommon, but it's there, and there are a lot of 15,000 children, more than 15,000 children were studied. HIV infected children have lower sero response, as I have also seen in the last few years study, and as compared to HIV unexposed or exposed children. So ongoing HIV viremia limits the successful vaccination in case, especially in case of FB. After 3 doses, 0, 1, 6 months. But in normal immunization schedule, we give at the birth dose, then the 6 weeks, 10 weeks, 14 weeks, and this means 4 doses we do give. And so 90 to 95% healthy individuals are protected. And only 20 to 70% HIV positive patients are protected. So it is better to see the seroconversion and the antibody level. If it's less than 10 units per ml, then again you have to vaccinate. So conclusion is 3-dose schedule for hepatitis B is not as effective in HIV positive compared to HIV negative person. So the undetectable viral loads have higher response. Chances of having protective antibodies higher in hepatitis B vaccinations. 3 double dose schedule in HIV positive patients. 100% response after in patient more than 200 CD4 cells. 47% response in less than 200. So you see, if the CD4 person is high, response rate is quite good. But if CD4 is less, then the response is quite less. Again, same with the pertussis vaccine, lower the HIV infected than exposed, lower antibody formations, and there's a study shows there's a decreased dose antibody response even after 3 to 4 doses in a HIV positive or exposed as compared to negative children. Now the safety issue, whether vaccine is safe or not, if the adverse events are there, which are more in HIV positive children or not, that is also a matter of concern. The vaccine safety, risk of disease with live vaccines. What is this? Immunization is generally safe and beneficial for children living with HIV or any immunocompromised personal children, except in case of some queries, some questions about the live vaccines. Although HIV-induced immune suppression reduces the benefit compared to the obtained in HIV unaffected. Means the level of antibody, the persistence of antibody may be less as compared to the HIV unaffected children. Unless the child has rapidly progressive HIV-related disease, usual routine vaccination should be offered according to the age, because in this particular patient, the immune system not so much immunosuppressed. Risk of disease and vaccine. Non-replicating vaccines are not associated with risks like kill vaccines, toxoids and all. BCG, measles, oral polio and yellow fever are the live vaccines, have reported to be associated with complications, severe depressive immunity. So we do consider the percentage of CD4 while giving the live vaccines. BCG vaccine immune suppression HIV usually takes several months to develop. Administration of BCG to HIV infected children in the first few months is associated with low rate of complication. So if you want to give, you have to give them either at birth or first few months, not after that. Progressive immune suppression can lead to reactivation of latent BCG organism. Sometimes it can cause BCG nosis or disseminated BCG infection. BCG after vaccination, there may be disseminated lesion in the body. Complication of BCG vaccination may be regional and extra-regional localized. It may be, when we do give the intradermal vaccine in the deltoid region of the left arm, there may be local axillary lymph node enlargement. There may be axillary lymph node enlargement. There may be suppuration. There may be dissemination. So regional lymph node, poor healing ulcer, that is localized, and there may be generalized reactions might be there in a severe immunosuppression. All depends upon the degree of immunosuppression. So a live vaccine not to be used if CD4 percent is less than 15% or in more than 5 years, or the adult is less than 200 CD4 cells per millimeter. And the live vaccines are MMR, varicella, yellow fever. Live is not to be used if safe or inactive alternative exists, like live intranasal influenza. There's a kill influenza vaccine is available, and kill poliomyelitis vaccine is also available. BCG should not be used in low endemicity country, although risk of adenitis is substantially reduced by early initiation of ART. So what is the immunization in children and the current guidelines? If you the latest guideline, you see the birth dose, we give BCG, oral polio, 0 dose, and Hep B birth dose. We say Hep B birth dose, not the first dose. Hep BD likha. 6 weeks, at 6 we give the OPB and pentavalent means there's a diphtheria, pertussis and tetanus with the HIV and hepatitis B. So 5 vaccines are there in pentavalent, then rotaviral vaccine, fractional dose of polio vaccine, FIPV. Why fractional? Because we give the intradermal. In private setup in IP, they said IPV, that they give IM. So you need IM, 0.5 ml, and intradermal is 0.1 ml. So the 5 doses, if you give the fractional dose of polio infected inactivated polio vaccine, you need 2 doses at 6 weeks and 14 weeks. Pneumococcal PC vaccine now all over. Previously, it was started at pilot mode in case of Bihar, Himachal Pradesh, Madhya Pradesh, Uttar Pradesh, and Rajasthan, Haryana state. Now, in this year, from 23, 20 onwards, 24 onwards, it will be in the national immunization schedule all over India. That is PCV. Then at 14 weeks again, OPV3, pentavalent, that 5 vaccines combining together, pentavalent 3 and fractional IPV2, rotaviral vaccines 3rd dose, and PCV conjugative vaccine 2nd dose. So these are up to 14 weeks, means 3.5 months. This is the primary immunization, and that must be received by all children of our country. And that is our duty to ensure to get this vaccination at appropriate time. So 9 to 12 months, what happens? Everyone is concerned with baby born, and everyone is very much gives importance to the kids, and they don't forget it's only the primary vaccinations given at say 6 weeks, 10 weeks, and 14 weeks. But at the time of 9 to 12 days to forget the vaccine, because there's a big gap. So it's our duty, if any child comes in contact with any healthcare personnel, you ask, especially mentioning whether the baby was given 9 months vaccine, 9 to 12 months vaccination or not, because usually we see in our experience they miss this one. The second booster has 16 to 24 months. That's MR2. Here MR. Some in private we call it MCV. MCV means measles containing vaccine. So measles containing vaccine is measles and rubella, and measles, rubella, mumps. MMR is also available. So second dose in 16 24 months, JE second dose, and of course DPT. Now after 1 year don't give the pentavalent. We separately give diphtheria, pertussis, tetanus boosters and OPV booster. At 5 to 6 years again, DPT booster 2. 10 years thereafter, we give the TD every 5 to 10 years interval. We can give the TD even in adult also. And pregnant mothers, we give the TD 1 and TD 2, or in the subsequent pregnancy within 1 year, 3 years, then we give 1 dose of TD booster. This is all of the national immunization schedule. So if you see the flow chart, at birth we give OPV, BCG and Hep B birth dose. Then at 6 weeks we give, again as said the chart previous slide, same is written in the flow chart. In pentavalent fractional IPV, rotaviral and pneumococcal vaccine. Then again 10 weeks, and then again 14 weeks. Then 9 to 12 months. Then 16 to 24 months, and then of course the boosters. And every 5 to 6 years one booster, then 10 years, then 16 years, then every 5 years TD is given. And now the HPV, human papillomavirus vaccine, you know, there's many 200 strains of HPV vaccine is there and identified. The country records a new case of cervical cancer every 4 months and 1 death every 7 minutes. Can you imagine the cause of death in women, especially women in our country every 7 minutes when women is dying of cervical cancer? So it's very important to prevent that, and that is preventable. In India, 2 HPV vaccines were licensed in 2008. A quadrivalent vaccine known as commercially Gardasil, and a bivalent vaccine called the Cervarix. And nonavalent vaccine is also available now. So the Gardasil nonavalent is also available. So mainly there are many strains are there, 200 strains. Mainly the 16 and 18 strain virus HPV, that human papillomavirus causes cancer, and that can cause the cervical cancer, anal cancer, vulval cancer, vaginal cancer, oropharyngeal cancer, not only cervical cancer. And in male it can go Watson, penile cancer, anal cancer also. So it can be prevented both in male and female. Both vaccine provides approximately 90% protection from cervical cancer, with the antibodies remaining stable for at least 10 years. So in India, launched the homemade product marketed in our country. It is developed in our country only, the Sarvavac, quadrivalent vaccine. So if you see these vaccines available, it is done by the some state of Maharashtra and Indian Academy of Pediatrics. This flow chart, you can, though it is not in government schedule, not in national immunization schedule, but it can be given by buying or by arranging some donation or by some from the other funds and all. It's very effective and should be given. I think each and every children, every child should get, male or female, both should get this vaccine. So if you see the name, the brand name Sarvavac is a quadrivalent vaccine. Gardasil 4 is a quadrivalent, and Gardasil 9 is nonavalent. The 9 strains are there. Now you see the Sarvavac, which is developed in our country, can be given, both can be given girls and boys up to 9 to 26 years. It doesn't mean it cannot be given beyond 26 years, but they have studied up to the age of 26 years. There's no study beyond that. But in Gardasil can be given in a female at 45, 9 to 45 years. And in case of Gardasil 9, that is nonavalent, the girls can be given up to 26 years from 9 years onward, and the boys up to 14 years. This only because the study is not done beyond 14 years of male and 26 years of females. And even if you give in HIV positive children, it is a 3 dose, 0, 2, and 6. But in case of non-positive children, non-HIV children, it is only up to 14 years, it is 2 doses, and beyond 14 years, it is 3 doses. So you need to initiate at 9 to 14 years, the best result to get. So it is always asked the adolescents, means 10 years, 9 years, after 9 years, they are going to the adolescent phase. Each and every ART center, you must advise and counsel about the HPV vaccine. So it can be started in 9 to 4 years, 9 to 14 years, and in HIV, it is 3 doses, that is 0, 2, and 6 months. But don't forget, because we are dealing with HIV exposed and infected children, so universal precaution need to be given, followed by giving injectable vaccines. Oh, we are giving the vaccine, there's no need to protection. No, even the vaccine, through giving the injections, you can get pricked and all. So you always take the universal precaution while giving the injection in a HIV positive children. Now, nothing is devoid of any adverse events. So similarly, the vaccines also. So adverse events following immunization, there's a term called AEFI. It may not be due to the vaccination or the vaccine agent itself. So what is AEFI? And AEFI is an untoward medical occurrence which follows immunization and which does not necessarily have a causal relationship with the uses of vaccine. Vaccine product related reaction, it may be vaccine product related reaction. It may be quality defect related. Immunization error without giving interdermal, you might have given the subcut or IM. So that may be complication will be high. Immunization anxiety related, especially in adolescent and adult also we have seen during the COVID time and all. In adolescents, especially when they see the syringe and the blood and the injection, they get fainted. So because of the error, anxiety, there may be syncope, there may be fainting attack and all. So that may be that should be included in the adverse event following immunization, but it is not directly with the vaccination. And there may be coincidental event. Suppose I was given the vaccine today and tomorrow maybe develop cough, cold, and respiratory pneumonia. So you have to inform as adverse event, may not be due to vaccine, but you have to inform it. So desirable vaccines are available in the country, though it's not in because of the cost effectiveness and all. It is still not in immunization schedule, like inactivated Hep A vaccine, inactivated influenza vaccine, varicella vaccine, single dose vaccine, though it's in pentavalent, no question of single dose of Hep B. Meningococcal conjugate vaccines are available in the market. You can arrange it by some NGOs or some funds and can give vaccines. This is the vaccines to be given in all, especially in HIV positive children, but not in immunization schedule, so we cannot give from the government setup. So these are the key points of my presentation. I mean, a detailed key points. HIV exposed infant, all other infants should be given BCG at birth. That to be taken in account, the BCG to be given all children irrespective of the HIV status. BCG has not been given birth, then it can be given up to 2 to 3 months. Thereafter, above that, you can want to give. If see the CD4 is more than 25%, then only can give. Children who are on receiving ART and not received BCG earlier, growing well, stable, not malnourished, immunologically stable, then you can give the BCG. Severe immunocompromised HIV infected infants and children or adolescents, even in young adult defined, should not receive any live vaccines. WHO recommend that additional dose of measles contained vaccine can be given, and we are giving it by IMI, intensive mission in the donors every year, of course, who are having the CD4 more than 25%. Supplemental dose of measles is given. Rotaviral vaccine, though live vaccine can be recommended in HIV exposed children. Vaccine virus is a highly attenuated virus, and though we give in primary immunization, it should be given. Nevertheless, like all live vaccine, it should not be given in children with known severe immunodeficiency, means CD4 count is quite low. Pneumococcal vaccines, we do give in as a PCV in our national immunization schedule, but we should remember that PCV is not sufficient for preventing pneumonia in immunocompromised children. You have to give pneumococcal polysaccharide vaccine, PPSV23. It should be administered at least 8 weeks after the last dose of PCV and another dose after 5 years. So this is not given in NIS, which we have to give extra. And of course, inactive Japanese encephalitis vaccines are safe. Is not in government schedule. It is desirable to check the seroconversion in case of Hep B. Always check the level which is available in all the parts of the country. So HIV infected children can safely receive all the vaccines as per NIS. Oral polio, internal influenza vaccine are indicated in severely immunocompromised children. BCG should be given at birth. Live vaccine should be avoided if CD4 is quite low. Rotaviral vaccine should be given in HIV exposed infant due to the risk of diarrhea. Inactivated Japanese encephalitis vaccine safe. Give additional booster in case of Hep B. Vitamin A, of course, we should not forget about the vitamin A supplementation, which is started from the 9 months, 18 months, and every 6 month interval up to 5 years. Desirable vaccines like HIV, hepatitis A, inactivated influenza, varicella, pneumococcal conjugate in typhoid. It's not conjugate, it's a polysaccharide and typhoid vaccines. Immunization status should be reviewed each and every visit as per the forest criteria you do in the ERT center. So this is the schedule taken from the National Immunization Schedule. I have taken from this contents. I thanks for this my acknowledgement with this Global Alliance Vaccine Immunization Action Coalition, World Health Organization, CDC, and IAP Immunization Schedule. Thank you. Now I'll stop sharing here. If any questions, I'll love to answer. So I'll
Thank you
stop
so much,
sharing.
ma'am. Thank you so much, ma'am.
Please
Ma'am,
type.
we'll just take the questions from the chat box. We are not giving mic
Yes.
access as at this
Okay, let
point.
me check the
Yeah,
questions
I'll
first.
read out the questions, ma'am. Can BCG vaccine be given to adults and what is its efficacy?
Just can BCG vaccine given to?
Adults and what is the efficacy?
It's not clear. Can given to elderly persons?
Adults. Yeah, elder persons.
Oh, adults. Okay, okay. Can BCG vaccine be given in adults and its efficacy? Okay. Now there is an adult BCG vaccination campaign is going on. It is already started in Delhi. In our state also we are going to start, but they will do the herbal screening. As I inquired about that, they don't rule out the LTBI, they won't rule out only verbal screening. And in case of, I don't think they were going to give it in HIV positive adults. And they are doing in a study mode, not in a government immunization schedule. They are doing in a pilot basis study mode to see the how much preventable is the LTBI from. LTBI means latent tuberculosis bacilli infection. Means there is a latent infection but not manifesting as a disease that can be prevented. But they have not included HIV positive adults.
Thank you, ma'am. Should all the live vaccines in the immunization schedule be given?
Yes, live vaccines can be given in as per normal immunization schedule, because I've already said the what we give live vaccines, especially in the primary immunization, that is 6 weeks, 10 weeks, and 14 weeks. And that time only hardly the child is the infant is 3.5 months old, and there's even though they have acquired the infection during birth, there is no such immunosuppression that can lead to attenuated organism to pathogenic organism. So you can give the live vaccine even in that age. Can BCG vaccine give in adult? Okay. Any other questions?
Can Shingrix be used in varicella as varicella vaccine?
No. So you can sing this. That is varicella vaccine. Varicella zoster vaccine is there. A separate vaccine is there for varicella zoster, and that is there in the adult schedule, not in pediatric schedule. So you can give in an adult, not in pediatrics. And varicella vaccine again same indication. If because it is the live vaccine, so we give in a when CD4 is quite high.
Cervarix vaccine
Cervarix
covers,
vaccine
yeah.
covers how many serotypes? So, if you see the that presentation and Cervarix, that the quadrivalent is there and the nonavalent is there. So in Cervarix is there is the quadrivalent Cervarix is there. So quadrivalent means only the 4 strains, and the main strain for cervical cancer is a 16 and 18. And 6 and 11 usually cause warts and others disease. So we want to prevent, and that if you give the Cervac, that is quadrivalent, is 85% protective. But if you give the nona valent, that is Gardasil 9, that is more than 90% protective, as per the study says.
Thank you so much, ma'am. No more questions in the chat box. Thank you so much for facilitating this session.
Thank you, Sita. Thank you.
Thank you, ma'am.
Thank you
Ma'am,
all
we
for
won't
hearing.
keep you waiting, but we'll just run the feedback form.
Okay.
Thank you, ma'am. Kiran sir, can we have the feedback form, please?
Feedback.
Thank you. Requesting all the participants to please attempt the feedback form and click the answers on your screen. There are 5 questions in all. Please attempt all the 5 questions. Requesting all the participants to please attempt the feedback poll. You can click the answers on your screen.
Shweta ma'am?
Yes,
Please
Shriva
repeat.
ma'am. Yeah,
Thank
it
you.
is just about the feedback poll.
Feedback.
Yeah. Kiran sir, we can end the feedback poll now.
In feedback form, I saw one is a disagree. May I know the reason of disagree?
No,
One
ma'am, it
person is
was the
written in disagree.
accidental.
I think there was 178.
Hital Thakkar ma'am, please check your connectivity.
Yes, ma'am.
It is for the participants. Kiran sir, we can end the e-poll now. Thank you to all the participants for patient listening. Thank you, Dr. Kalpana ma'am, for facilitating this session. Thank you, everyone. We'll conclude the session now.
Thank you all.